term. When we think about looking ahead in our medical trajectory, the type of care, whether medical or otherwise, that we may want to think about to better prepare. So I would really view advanced care planning as kind of the global picture, as a way for us to think through how our life may change, whether socially and or medically, as our medical condition changes and progresses.
Then what's an advanced directive? So,
Sure. So when you think about advanced directives and most, I would say that advanced directives fall underneath the umbrella of advanced care planning, right? So advanced directives, usually every state may have their own version of advanced directives that you can download for free. And there are also organizations that put out their own specific advanced directives that patients can consider using, such as 5 Wishes or Voicing My Choices. And those are a document in which patients can take in, and it'll lead them through different care decisions that they may want to start thinking about or think through. And so typically all advanced directives will have at least 2 sections, right? Section 1 typically would be identifying a healthcare proxy. So if I am not able to, for whatever reason, make medical decisions, who would I entrust to make decisions on my behalf? Right? I think so it's important to realize it's different from a financial power of attorney, so like healthcare power of attorney or healthcare proxy. And then the second section that's commonly in an advanced directive would be, under certain medical condition, what are my wishes regarding life-sustaining therapies, right? So they usually would identify 3 conditions generally in which we're expecting a person not to have the ability to make healthcare decisions. So usually end of near death. The second would be coma. Third would be persistent vegetative state. So under these 3 circumstances, some advanced directives will give options or boxes to check as to what your preferences may be. So those are kind of the bare bone of most advanced directives, and it's really a way for the patient to express their ideas and their thoughts regarding what their preference may be.
So definitely not making that distinction between healthcare power of attorney and a financial power of attorney. Those are two different, separate.
Right.
And what's the MOLST form? So what makes it different, or how does it tie to advanced directives?
Sure. So MOLST form is medical orders. So these are actual orders from healthcare providers after a conversation with patients or the patient's proxy about certain medical interventions. So these are, if somebody gets admitted to a hospital, a physician, nurse practitioner, PA will have to put in admission orders or diet orders. So again, MOLST consists of a series of orders, medical orders, that after a conversation with patients and or their proxy, they would make certain selections. So for example, decisions regarding code status, decisions regarding dialysis, artificial nutrition, hydration. I think the difference is that a MOLST needs to be completed by a healthcare professional, whereas an advanced directive is one that is coming from the patient's perspective.
Now, do you use what the patient has in their advanced directive to guide their care plan or what they want done in the MOLST form? So is it helpful to have an advanced directive to complete that MOLST form?
So I think ideally it would be wonderful to have the patient's advanced directives to serve as what I would say a compass, if you will, as a starting point. Our goal is certainly to respect the patient's wishes if it's previously stated in an advanced directive. Now, we know that in real life situations, there there may be times in which the reality is hard to reflect the ideal. But, ideally, the advanced directives should serve to inform kind of the healthcare decisions and orders that are made.
So in that sense, we do have to have those advanced directives and conversations about, we have to plan to have those forms completed and ready to go before a life-threatening or a terminal illness strikes.
I think ideally at least have, if not written down, then a conversation about what's important for the person.
Right.
So yes.
Yeah. So with that said, what matters most at end of life for the Chinese, Chinese Americans? So what attitudes do Chinese Americans have towards advanced care planning and end of life? And when we say that, we want to keep in mind that to our audience that we're talking in a generalized term, and don't want to disregard individual preferences in this sense. But just generally speaking, what matters most at end of life for Chinese Americans? It could be for either one of you, so Dr. Chang or Keely.
So I think Dr. Chang has a very good presentation from a study that she participates for, and when I look at the result, I keep knocking my head. Yes, that's how we feel. So I have Dr. Chang to talk about it.
So I actually was not a participant in this study. However, somebody from University of Maryland kind of spearheaded the study. So it's very local, and the study was done at a local Chinese community, 60 participants. And these 60 participants were divided and participated in 10 focus groups. And 9 of the focus groups were conducted in Mandarin and 1 in Cantonese. And what the participants were asked to do is to play this game called Go Wish, the Go Wish game. And the Go Wish game consists of 36 cards. And on each card, there's an item that may be an important, may be viewed as important at end of life, right? So an example would be to trust my doctor, to maintain my dignity. So each of these cards have a statement. And then each participant within their focus group are asked then to individually rank the top 5 cards for them. And they'll rank it from 1 to 5, 1 being the most important to them at the end of life, and 5 being least. And so there certainly are cards that they may not use in this ranking. And what they found, and what you see in the next slide, is that looking at 60 participants' answers and how they rank, what are some of the top things that are important to them. This is what we found for this community. So the number one concern for this group is that they want to make sure they're free from pain. Right? So that's the number one that floated to the top. And that's followed by not being a burden to my family, then to have my family with me, to trust my doctor, to maintain my dignity, and to pray. So interestingly, cards that were not used were to have human touch, to be able to talk about what death means, to die at home, and to talk about what scares me. Right? And I think it's important, I just want to pause and reiterate how we want to make sure everybody knows that this is a generalized kind of data that we get. Well, we shouldn't generalize this data into everybody, right? But certainly for this particular 60 participants in a local Chinese community, local to Maryland, that this is how the ranking came out to be. And I find that at least clinically, the top 2, to be free from pain, to not be a burden, that is a theme that comes up regularly. And I think it also plays out in how patients and also family may choose to approach the conversation about advanced care planning. And then also, even though Pew Research study years ago have asked, and surveyed Americans, where is your preferred location of death? And 80% or so said home. But I thought it was very interesting that, at least in this particular study, to die at home, that card was never picked up by any of the 60 participants. So I think the angle of how we bring up the benefit of hospice services can be tailored to, meeting kind of some of the top concerns of patients and families and gearing it more towards good symptom management, helping relieve kind of some of that care burden from the caregivers. Go ahead.
And then so I don't quite know the background of the participant. What is how much do they know the care system, the end of life care system in the U.S. and the age and different, do they have a condition? So this really, I think, would give a different answer for the cause that they pick. But when I look at not to being a burden of my family, I would think, the more people you ask, this would come up more often. It's kind of by default that you stay with your family at the end of life, and then it's kind of a traditional way of thinking that family take care of each other. Right. So there's a little bit cultural aspect in it. Yeah.
I think you're right. This is something we also see in hospice and palliative care is don't want to be in pain, right? And hospice pain management is our bread and butter of the whole care model, because if you manage pain, then I think perhaps they can also focus on then the other aspects of life. So human touch, so focusing on connecting with others. And so I think at the top of the list, I would even personally, I would want to be, as a human being, I would want to be free of pain. I don't want to be, of course, a burden to loved ones. So I can definitely see some of why some of them some of the cards weren't picked. Yeah, so it's very interesting.
It's very interesting.
So how do you initiate conversations about advanced care planning with clients and patients in general?
So in CCACC Chinese Culture and Community Service Center, we actually have several programs, and one of them is Adult Daycare Center. On a daily basis, we serve 250 seniors from the age of typically 70 to 100. So it's actually part of a job for the social worker in the daycare. In the intake, they ask that question, do you have advance directive? It's a building question. So really depends on where the patient is. They might have been asked in the primary care doctor's office. They might have been asked one time when they were in the hospital, they asked that question. Or they might be senior, never been asked, or they just pass that question. So I think it's really important at the intake, we just bring it up just as any other question, just as what's your name, how old you are, and do you have advance directive. And then if they have the interest, then we go more and tell them what it is and what different kind of care planning and a different document. If they don't have interest or they kind of like don't want to talk about it now, we always tell them we are here and we are not like saying you should not. But if you're interested in knowing more, just come to me anytime. And so I think it's important that it's just like any psychosocial service, we need to be knowledgeable and we need to be calm and just deliver the message.
So routinely having the conversation, just making it as routine and casual as possible.
Yes, routinely. And then we also have a psychosocial group kind of every month and talk about different hot topics like depression, like Alzheimer's disease. We just have that. And then it naturally come up, bring up the question of advanced directive, advanced care planning. And in a group setting, seniors are, I feel it more easily to open to it or even just listen to it.
And do you have anything to add to this,
Sure.
Dr. Chang? How do you initiate conversations about end-of life or advanced care planning with the patients that you see, given your background?
I think two things, and one I want to dovetail on what Kate was saying. So there are qualitative studies looking at exploring how Chinese American preference may be in having these conversations. And again, I don't want people to stereotype, but I think in general, what these qualitative studies have found, one thing that floats to the top is being able to, as Kate said, talk about maybe a friend or a family member or even an acquaintance that might have gone through the end-of-life process if they've either participated in or were peripherally aware of, and they feel more comfortable when it's talking about, well, when my friend went through her last couple of weeks, this is what I saw, and this is what I would want, or I wouldn't want that. So having the ability to talk about it in the context of another person's experience had floated up to the top in terms of how to begin thinking about and having those conversations. And then a related theme would be kind of starting more with the indirect, starting more with the general concept of, well, we want to talk about what are some things that are very important to you. Tell me about that. And then, should your health status change, what are some things that are very important to you, or what are some things that you really worry about? So starting from the global rather than jumping right to like, hey, here's a form. I want to just, I think it just more kind of start titrating your directness to what the patient can accept. And I think then that comes to my second point of, I think it's important before we dive into these at times emotionally difficult conversations with patients and family, we have to start from a place of trust. Like they have to know that we care about them, that medically, health-wise, and that what we will suggest, what we want to talk about is out of the best interest for you or for your mom or your dad. I think that needs to be the first step. And that's probably crosses culture, I would imagine.
Yeah, it's so true that we need the relationship in place before we can start the conversation. So it will be the relationship between the provider, the professional, and the patient. And I think it's even important that the family and the caregiver, they should have a relationship that can openly discuss different topics. Because it's a new thing in our culture. Openly discuss any emotional feelings, difficulty. So it's not naturally in every family. And then the other thing is that some people in the community, they have this belief that once you raise the topic, it's kind of the Pandora stuff. I was fine until you raised that topic, then things keep happening like the end of. You see what I mean? So that's why people would avoid. So I used to have a social work intern, and one of his job is to check in the advance directive in file, and then maybe just talk to people when senior needs the information. And eventually people knows that her role is to do this. And she said, I feel like I'm the more sea when he walked through the ocean. The water just apart.
Like Moses, parts of Red Sea.
Yes, and then when she walked through the lobby, and Cindy just like, it's like a burnt eye contact. Yeah, it's just like, I'm the messenger. Yeah. So just only because she have, like, people knows that she had the advance directive form. So that go back to that people would seniors would need to have more exposure and know what it is about, not to avoid, not to think that it's something that I give it to you doesn't mean there's anything, doesn't mean anything about your diagnosis, anything about your care, anything, related.
But that's interesting because I think just beyond even talking about death and dying, just the form itself could sometimes signify, it can be a hindrance and a barrier to starting the conversation.
Right.
So how do you then navigate around that and try to approach the conversation in a more casual way with your clients and residents?
Right. So like I said, it's important to give the concept at the beginning, and if they might not register, but then we put a regular health information in place, and then sometimes we also have some discussion, like the case Dr. Chang mentioned about that a patient maybe have Alzheimer, and then the family are fighting in the hospital, like different family members, they are fighting. And then we can just bring this up in our casual talk, and then we will suggest that if you really think about, I should talk to my family, you can just, in a dinner table, hey, it's happening in the center. And if I were that lady, I would like to, what's the option? So just lay it out casually. So I mean, at least your family knows the preference, right? It might not be on the paper. I mean, whenever they need to put things down on the paper, it really scares them off. And I see a lot of advance directives we help to fill out. It's all like they check everything. they check. I wanted to fill in. I don't want to fill in the next one. So I can tell the emotion and the overwhelming when they're right. So it normally takes them several times to complete it correctly.
And I mean, the reality is there are recent cases where I had a really in-depth, long conversation with a patient, a Chinese patient from China for cancer treatment, and had a long, in-depth conversation about advanced care planning, what's important to them, when as specific as the type of intensive intervention they don't want or do want as their disease progresses. And at the end, I handed them an advance directive, and then they opened it, and it's kind of like, I don't know how to fill this out, and even though I then go through the pages with them, there is a sense of reluctance of putting things down. Sometimes the reassurance of you can change it at any time, it's not set in stone, and that will be enough to alleviate that worry, sometimes not. And sometimes the check boxes are just confusing because it's hard to think through like coma and then like, I think near death that may be more comprehensible, but there's some other sections that it's just hard to imagine. But I also want to say that I've also worked with Chinese patients who are like all about the advance directives and definitely want to form, they want the security of having those things in place. So I think this pulls in the idea of different levels of acculturation, right? That different patients and even family members may have, and even people who might have immigrated here same amount of time may have different levels of acculturation to the idea of, want to make sure to have all the forms filled out versus more of what we think is the traditional Chinese approach.
And I think one part of it is that maybe people don't know much about the care, the different therapy, what it means, what is the best. So before they know it and they have to make a decision, it's kind of hard. Yeah. And then go back to how to make it easier to start the conversation. So I always share my own experience. I'm in my mid-40s, and I have 2 kids, and my husband and I are the only one live here in this country. So it's natural for me to think about if something happened. we drive a car every day, and he drove the highway every day. So I mean, it's just with everybody. And I told the senior, I set up something, set up a trust, like, yeah, who do I give my children to if something happen? And it's just something to give you peace of mind. And it's the same thing with advance directive. And it's the same thing. I have one too, advance directive, right? Like I said, anything would happen. So I think it's easier for the senior to relate to that. I say this advance directive doesn't. It's not my doctor is saying I only have 10 days to live. It's nothing to do with that. It's just a plan. It's just like buying a life insurance, right? It's something like that. It's neutral. So that way it's easier and make the conversation go easy.
And we talk about advanced directives and advanced care planning more in like in terms of seniors and the elderly, but I think we need to normalize that the conversation needs to occur even with young individuals as a part of a routine care as we go for our annual checkups and such, that it should start early so that it's not a shock and that what we want as a way of medical intervention should be clear. And it could evolve, right? That's my understanding, right? That the documents can change as we age, as our health conditions change from whether healthy to non-healthy and ill. And so it's just always good to have that document or even a conversation to start early on, would you say? Yeah.
And I think it's important to allow senior people have multiple, like they can multiple encounter with the conversation. It's just not like, don't feel bad if a professional didn't get that advance directive. At least we mention it, and next time maybe she knows better, and then think about it, and then eventually they will make a decision. And the other thing is that it's kind of a learning process with all the concepts we talked about earlier on, right? Different documentation, different arrangement, and we need to know how much the patient knows. The system. We don't assume they should already know everything in detail, and then they're ready to make that decision. Right? So if they're not there to make a decision yet, maybe they need more education.
So I think we touched on this a bit, but are there differences in which illness and death are approached in the Chinese culture that makes it a little unique from, say, the Western and other cultural perspectives?
I think this is a good place for me to share a very interesting study, if that's okay.
Yeah, absolutely.
So this study was done in China, Shandong province, at a tertiary hospital that provides cancer treatment. And this study specifically want to look at this perception that people have about how telling the truth, like truth-telling about serious illness, is a taboo concept. And I find the study very interesting because, in essence, the answer is, well, let me just go through a study and then walk you guys through it. So the researchers recruited 124 patients and a family member consecutively, patients coming to the cancer center for cancer treatment. And they recruited these patient and family pair, but then interviewed them separately. And for the patient, the researcher would ask them, first, do you know why you're coming to the hospital? To see if they know what diagnosis they have. And then they will ask, just in general, to the patient, do you think patients should be told if they have a terminal condition? And then there are subsequent follow-up questions. What they found is, in this group of 124 patients, only about 37% of the patients knew of their diagnosis. But then when they were asked, do you think patients should be told if they have a terminal illness, even the group of patients that did not know of their own diagnosis, I want to make sure I get the number right, 87% of those patients, 87% of those patients who did not know about their own diagnosis feel that patients should be told. And this is in contrast to the family pairing of the non-disclosed group, where majority of the family members said no. Only 32.5% of the family of that group felt like patients should be told. So there's an innate discrepancy. However, it doesn't end there, because the researchers then asked the patients, well, two more questions. One is, who do you think should tell the diagnosis? Should it be a healthcare professional, like a physician, or should it be coming from a family member? And then the second question is, at what pace should this diagnosis be revealed to a patient, right? And so what they found was a third of the patients feel like family should be the one to disclose the diagnosis. So it's a significant minority, a third, right? And then the pace at which the diagnosis is revealed, again, about a third of the patient feels that the diagnosis should be disclosed gradually according to the type of treatment they're going to receive. So if they're going to a hospital to receive cancer treatment, then more and more will be revealed and told, rather than giving the diagnosis right away, like from the get-go. And so I think the takeaway for me from this study is that, again, in general, Chinese patients do want to know the truth, however, buffered by family, right? And that oftentimes family are compelled to protect the patient from existential distress. And that also what I'm seeing is there exists a percentage of patients who do not want to know, right? So I think it's important to acknowledge and recognize that. But I thought that was a powerful study that really dived into more of the nuance, right? Beyond like the question of is truth-telling a taboo, like it really dives into kind of the nuance of the relationship that patient and family have for each other.
Yeah, that's interesting. I mean, so like family members also play like a significant role in that decision making, especially if they're playing the buffer in which like information is disclosed to the patient, right? So what is, you've touched on it, Dr. Cheng, but what is the role of a family member, families in general, when it comes to end of life decision making?
I think it can be huge, right? Again, like we have to meet the patient and the family unit where they are. So again, we're all speaking in generalities, but I think it's important to say each patient encounter, family encounter may be different. I would say that in general, family do play a very important role. And sometimes I almost make the analogy of pediatric patients and how the role of parents for kids with serious illness, that type of tight relationship and dynamics. And Kate, you can probably speak more to the daycare center, that dynamic between patient and family.
So traditionally, the oldest son will have all the authority, taking care of everything. But I don't see that much in the Asian American culture, that much. But I do see that in a family unit between several siblings, they always have a leader, a kind of leader in healthcare for the senior, that would take care of the decision-making process. And there might be other family members who actually do the caregiving, the IDLs for the senior. So there may be a separate role. So identify who is the key decision maker. It's I think it's kind of important. So we can actually ask the family too about this. And the other thing is that in the study, I can come up with the theme that it's always the family wants to protect the patient, and the patient doesn't want to be the burden of the family. It really comes to a circle. Yes.
Yeah.
Yes. Why? I mean, I would understand everybody don't want to be a circle, a burden, right? But then there's another layer to it is that they don't want their loved one to be a burden. So no, don't to burden their loved one. So that's this consideration.
Yeah. Interesting. So what do you believe best help your patients and their families comprehend the content better? So I think we went over some steps and practical steps that we can take. And Kate, you mentioned that gradual introduction, continuously intentional conversations, and then acknowledging family members' roles in that conversation, and then also including them, recognizing. So what do you believe best help your patients and their families comprehend? What's one thing that you can say is?
Yeah, when you ask this, I think it's important, not the patient themselves. The family need education too. It's most of the time, I mean, sometimes we have senior come up to us and ask us to talk to the parent, the family, that they want to have this. They want to have a conversation at least, and the family doesn't want to like get into it. It's too much, and maybe like for a young person, it's too much for them to even think about it. When something is unknown, it's fearful, it's hard to think of. So I think the family members or caregiver, we also would need to look into like giving them information and what this is about. This is not a verdict of your treatment. It's actually just some information to think about. Maybe the patient wants you to think about that too.
So switching gears to what are the most significant barriers to having conversations, not about advanced care planning, because I feel like we touched on that a lot, but about hospice and palliative care specifically. I can tell you from my own experience, coming from a culture that where talking about death and dying is a taboo, that by talking about death, it's considered. I'm Ethiopian for our audience. It is considered, by speaking about it, you're even bringing it sooner, and so you avoid it all in general.
Yeah.
So what are some of the barriers when it comes to addressing hospice and palliative care in the Chinese or Asian culture in general?
I think the myth is that once you get hospice, there's no way back. So I think that's the biggest. And then people just like afraid of making wrong decision. Yeah.
I think there's fundamentally some people may not know what hospice and palliative care is. I just had a conversation with a Chinese patient who his biggest fear at the end of life is to be in pain. You know, and so I brought up the hospice services, and that was a brand new concept. And so is palliative care. And so I think, and that's not in isolation to Chinese community. I think that's lack of understanding of what hospice and palliative care is can still be pervasive in many cultures as well. So I think part of it is explaining what it is, and part of it, at least for hospice services, kind of the payment piece, you know, because that's really quickly the next question after hospice is brought up is, well, I don't know if I can afford it or if I don't have insurance. So I think also educating the care providers about how to answer some of these more common questions about how, many hospices have the ability to provide services even for people without insurance. I think can help keep that door open with families who may have some financial concerns, and maybe the initial care provider doesn't have that knowledge, then that door gets closed prematurely. And as Kate said, there, can be fears about, am I going to miss out on things by then signing up on other things? So sometimes palliative care is a nice bridge to be able to say, at least when it's available, and more often in the hospital setting, that you can have palliative care specialists concurrently while you're receiving treatment. And then when the timing is more ripe for hospice, and say, well, there's a team that's just like our team, and but they can help you at home and more in the community setting.
And it makes the conversation in palliative care valuable, right? The transition, changing the conversation from, hey, we're palliating now to hospice, end of life care, and with the prognosis of 6 months or less. So that conversation is easier when you have when the conversation starts earlier. And here, as you said, here at Montgomery Hospice, what we try to do is address those common misconceptions about hospice and palliative care, and through our educational programs. Payment is a huge thing. How do you pay for hospice and palliative care services? And, it's paid by Medicare, Medicaid, and here, being a nonprofit organization, we also, if a person doesn't have an insurance, Montgomery Hospice covers for the patient. So it really is just educating ourselves and knowing the information and empowering ourselves with the tools and knowledge so that we can tap in when we need it. So
I refer an insured patient to Montgomery Hospice, and I was with that the patient at the very end. So the family, she's a new, actually a visitor to the country. So her family, because they have no knowledge about what it is, till the end they really appreciate having that time to have a proper. So I think I want to mention is that we don't, in China, we don't have a system, end of life treatment system like the one in the U.S. So there's no comparison, nothing to reference to. So that's why education is so important, and understand how much they know, and then we
I think this would be a great time for us to take questions from our audience. So we have a question or a statement from Susan. I usually tell the family members that when the time comes, they can decide to change their minds and send their patient to hospitals if necessary. But the patient will be discharged from hospice while patient is in hospital. They usually feel better if they do have a choice when the time comes. And I couldn't agree more with that. So just having a choice and really is understanding what a hospice is and the services that are provided. So by being aware of the whole concept itself could be a good start. Do we have any questions? We do have about 9 minutes that we left for you. So if you have any questions, you may raise your hand, and we might try something. If you have a mic, that I might unmute you and take your question live. So if you have any questions, please go ahead and type them in the chat box. So we have a question from Jonathan here. Just so I can make sure I understand, is a competent of later life care with Chinese American families that the patient wants or expects the family to be decision makers or managers for their health, whereas patients of other population might be more concerned about keeping a much decision-making power for themselves. Do you understand that question?
It sounds as if the question is there a propensity for, within the Chinese culture, to prefer family members to take over decision making, whereas other cultures may be more of a autonomous patient taking the lead in making their own healthcare decision. Is how I'm reading it. And it's interesting, Jonathan, that you bring this up, because there actually was a study that's looking at how decisions are made within Chinese American as compared to European American, and this is in the realm of mental health decisions. So we can kind of extrapolate and learn some things. And so the researchers recruited from these three populations. So Chinese living in China, Chinese Americans living in the U.S., and European Americans. And they were given three different case scenarios. One that is doctor-led decision-making, meaning the physician ultimately decided what will happen with this patient's care, even if it was counter to what the patient's preference is. Mm-hmm. And then the second scenario is family-centered decision-making. So ultimately, it's the family making a decision for the patient. And then the third scenario is more of the shared decision-making model, which is more familiar to kind of the Western culture, where the patient ultimately makes a decision for themselves, even if it's not the top recommendation by the physician. And so they gave these participants these three scenarios. What they found was Chinese living in China, overall, of those that they surveyed, their top preference is actually doctor-led decision-making, followed by family-centered decision-making, and then least is shared decision-making model, which we're all more familiar with in the Western. The Chinese Americans, well, let me go to European Americans. So their number one preferred overall is shared decision-making model, followed by doctor-led decision-making model, and then the last is family-centered decision-making. And then Chinese American kind of fall somewhat in the middle. So overall, their preference is also shared decision-making model, followed by doctor-led, and the least is family-centered. So I guess, Jonathan, what that shows me is one has to consider the degree of acculturation that when you go and visit a Chinese patient and their family members, one has to be open to finding out how much the patient themselves are acculturated to more of the Western approach of decision-making and self-determination, and how much are they more relying on kind of doctor-led or family-centered decision-making, where it'll be more of, I want my family to decide for me. And to give you an example, my grandfather, who probably has liver cancer, his preference was not to be told about the diagnosis. He was very clear. He did not want to know and just wanted to defer everything to the family. And then we have a family friend who's similar age as my grandfather, immigrated around the same time, who developed lung cancer, and he wanted to know every single detail. He called me over to make sure we do advanced directives together, and he, was very much involved in his healthcare decision. So I think we must be mindful that whoever you meet may run the spectrum of their preference.
Great. I will take one more question. I understand there is no hospice in China. If not, is there an effort to introduce it in China? Kate, do you want to take that?
Is Mindy doing something like that?
Actually, there is. I read the research that there is. They started a hospice in Hong Kong, I believe. And Mindy, who is my colleague working from China, is saying they have started a hospice in China. So we'll look into that and send you more information, Hannah, on that. So with that said, I really do want to go ahead and wrap things. Oh, we have Okay, we have one more question. You said trust in doctors is really important. Can you share a quality that inspires trust in doctors or healthcare providers for members of the Chinese community?
What inspires? I'm sorry, can you say that question?
So you said trust in doctors is really important. What inspires doctors?
I think showing respect.
Mm-hmm.
Showing respect, and gotta remember, it's the patient
Mm-hmm.
and the family. Showing respect and being willing to listen to the patient and the family. Even if you're faced with requests that you're like, take a deep breath and be willing to sit there and listen. I think showing that degree of respect to the patient and family is a good step towards trust.
Mm-hmm. And I think keep the patient and the family informed
Mm-hmm.
as much as you can. I think it's very important. I think nowadays, I mean, doctors are very busy. No,
As is everyone else.
as everyone else. Yeah, so I think to be informed it's important in the decision making.
And we did this webinar about 5 months ago where we focused on the African American perspective on advanced care planning. And when I see the same sort of things, kind of, although there's differences, just a few differences, one thing that our physician, Dr. Coleman, mentioned was really being respectful is an occurring theme. And then and he actually talked about just when he approaches a family, he sits down, so he to make sure that he's conveying that he's there, he's not in a rush, he's there. So respecting the family's time. So that's something, and I just remembered that it is a recurring theme that we're seeing, and keeping them informed, like you said. I think we've.
And also, I think don't think that we are so much different.
That's right.
So I went to the Natural Museum, and I was told by one of the exhibits that we are 99.999 similar.
Yeah.
Just that 0.0001 make us different. So so really don't be scared of the little difference.
Yes.
And what we shared today is not one size fits all again, and then like we are the same at the core.
We want to be
we want, we do, but we also want to bring our diverse community into the platform and kind of share our become culturally aware and cognitive, so that when we're providing care for the different diverse groups that we have here, we are aware and respectful of those cultures and traditions that they keep and we keep dear to our hearts. And so it is 1 o'clock. I'm going to go ahead and wrap things up. I did see a question from one of our participants that I missed, but I will get back to you in the follow-up email. We're going to share all the resources that were shared today with you in the follow-up. I will also ask you to complete an evaluation form. Magna or Alejandra would be sharing a link to our electronic version of our evaluation form. Please take the time to complete the form. We use it to not only improve our programs, but to see what we could talk about next and bring and address any issues that you think we should address in this field. I thank you for your time. If you signed up for CEU, you'll receive it in about 2 weeks. And I want to say thank you, a huge thanks to our panelists for giving us their time and their wisdom and their resources and knowledge. And we hope to continue this series next year. This is our last one in this series. And we have one more webinar coming up on December 4th. It would be on managing grief and loss through the holidays. We are going to incorporate songs, stories, and music therapists. We've invited about a music therapist, We have a physician who's going to be joining that conversation. So that would be a great way to end our year, really. Thank you so much for joining us.
Thank
Thank you.
Thank